Hello, everyone, and welcome to today's program. Today's program will be presented by Kim Huey and is entitled 2024 CPT Code Changes Accurately Meet January 1 Deadline. All participants are in listen-only mode, and at the end of this webinar, you'll have a chance to ask Kim all of your questions. Just use the chat box on the webinar toolbar to submit your questions. Please know that all questions will be addressed at the end of this webinar. As I mentioned, our speaker for today is Kim Huey. Kim is an independent coding and reimbursement consultant providing audit training and oversight of coding and reimbursement functions for physicians. Let's go ahead and get started. Welcome, Kim.
Thank you, Samantha, and thank you everyone for joining us. As we get ready for next year, we've got just a little over 2 weeks, and if you take out our time for the holidays, we don't even have 2 weeks to get ready for the CPT changes for next year. Of course, that's what we're focusing on today. We've previously had webinars where we talked about the ICD-10 changes and then also the Medicare changes. Today, we're focused on CPT. So I always like to kind of give you an idea of where does she get this information from. So one of the sort of benefits I have is I'm an author of a textbook for physician coding, actually CPT for physicians and facilities. And because of that, I do get a file of the CPT changes. It's just an Excel file. I get that the 1st of August. And then I get my book along with you about the 1st to mid-October. And then the big place where I get most of the information that I'm going to share with you is at the AMA CPT Symposium. It is my very favorite conference of anything I've ever attended. I've attended every year for over 25 years. Used to be in Chicago, so we'd go middle of November, have a little shopping, some really good food. Of course, since COVID, it is remote, but that does give more people a chance to attend. So if you ever have a chance to attend that, I just encourage you to do it. It's a 2.5-day symposium, and the doctors who write the codes explain them. They go into all the detail about why we needed a new code, what's the anatomy, really such rich detail you just can't get anywhere else. And then you do have the Medicare medical directors that will explain, okay, this, are we going to pay it? Are we not going to pay it? What documentation do we want to see? What's the medical necessity? So you get all of that information. So I would encourage you, if you have a chance to attend that in the future, please do so. It is, as I said, mid-November every year, and again, just the best place for information. So that's where I get what I'm sharing with you today. I always like to start with just an overview so you can see where our new codes are coming from or what sections they're in. So you can see E&M, we have 1 new code, 26 deleted, 50 revised. Don't panic with those numbers. It is really a very minimal change to E&M compared to what we've had the last 3 years. Remember 2023 and then 2021, just massive overhaul. It's really just tweaking things to kind of bring some consistency and bring them in line. So don't worry about that. We'll talk about it. Anesthesia had no coding changes again this year, so anesthesia is can be a difficult specialty to code, but they haven't had to change anything for the last few years. Surgery, now remember that is everything from integumentary all the way through nervous and eyes and ears, so the 10,000 through the 60,000s. We have 33 new codes, 19 deleted, 20 revised. Radiology, 1 new code, 5 revised codes. Path and Lab, we have 12 new codes, 4 revised codes. Now, also draw your attention when we talk about lab to that bottom line, the PLA. That's the proprietary laboratory analyses codes. Remember, those are the codes that end in the letter U. They do not go through the regular CPT process. It's just a matter of, hey, give us a code. We do something on humans, give us a code, and CPT has to give them a code. So I'm not going to talk about those. Just remember, though, if you purchase a kit or you use a test and that vendor is giving you a code that ends in the letter U, you have to use that code. You cannot find another code in the lab section that looks similar. And again, it's because that test has not been through the regular CPT process. Then medicine section, we have 38 new codes, 9 revised. Category 2, no changes this year. Remember, the Category 2 codes are those that end in the letter F, and those are your quality reporting. So some of you may not use those at all if you report your quality measures some other way, but some of you add those to the claims to report those quality indicators. And then the Category 3 codes, those end in the letter T for new technology. Now, remember those Category 3 codes. We have to use that code rather than an unlisted code if we have that. These services, we either don't know whether they're going to be done all over the country, we don't know how often they're going to be done. Some of them are not yet FDA approved, so we have to use that Category 3 code. Now, one of the things I've done the last few years as I've organized these updates is that I don't put Category 3 at the end anymore. I include it throughout the presentation whichever body system that code would come into. So you'll see them throughout. And to me, it made more sense organizing it that way. But I was speaking with someone last week and they said, oh, I like when you do that because that way I get a heads up in case my doctor might think of doing something that he hears about at a conference. So I haven't thought about it that way. But here's maybe a preliminary heads up if the doctor wants to do something new. So we have a total of 11,163 CPT codes at this point. So first of all, the evaluation management update, the first thing they did was make revisions to the guidelines when there are multiple E&M services on the same day. We'll talk about those individually. First of all, time is never counted twice. Well, we knew that, but CPT comes out and says it. Inter-facility of transfer of care does not constitute a new stay. If you're still in the same facility, you cannot then bill an initial visit just because the patient's transferred within the facility. Time in the emergency department can count toward the total time when billing another E&M service. Now remember, we cannot bill emergency department codes based on time. But if another service is provided in the ED and it is time-based, we can use that. Or if we've got a patient that may be seen in the ED and seen as an initial inpatient care or seen somewhere else, all of that time can be combined to bill toward that appropriate level of service. Also, we've got a little nod from CPT to CMS about something that changed last year. Remember last year, CPT said, you remember that long-standing rule that you can never bill two E&Ms the same day? If you see a patient in the office admitted to the hospital, you can't bill both? And last year, CPT said, well, yes, you can. We think the work is separate significantly enough that you should bill both. So CPT gave us that new rule last year. Medicare said, nope, we are not changing our rule. You still can only bill one or the other. So what CPT says now is, yes, we still feel like you should be able to bill both. However, if you're working with a payer who will not allow you to bill both, then you can choose whichever one you want to bill. So if you're talking an office visit or hospital admission, whichever one you want to bill, either one is going to be correct. Now, what you can also do, though, is take all of the time spent, regardless of the site of service, and apply it to whatever code you're going to bill. So if you're going to bill the hospital admission, then you can take all your office visit time, add it together, and then you could choose that appropriate level of service. If you're going to do that and you end up with a prolonged services code, just remember your prolonged services code needs to match your base code. That is, if you're billing an office visit base code, your prolonged services code needs to be the office. If you're billing hospital, prolonged services needs to be the hospital. They also increased the threshold times for a couple of the initial and subsequent nursing facility care codes. So 99306, the threshold is now 50 minutes. 99308, the threshold is now 20 minutes. For office and other outpatient codes, they replaced that time range with a threshold time. Now, realistically, that's not going to have an overall effect on our coding, but office and other outpatient services were the only category that had a range and not a threshold. But, for example, 99203 was 15 to 29 minutes as the range. Now it's 15 minutes is the threshold, and then 99204 is 30 minutes is the threshold. So it really means the same thing. You end up at the same code, just that code description is different there. They also clarified that the CPT time rule of midpoint does not apply when you have the E&M guidelines of the threshold time. Well, what do I mean by that? Remember that we have some CPT codes that are time-based and that they have what I call the halfway there rule. CPT calls it midpoint, I call it halfway there. So if you get halfway to that code amount, you can bill that code. So for example, the physical therapy codes, they're 15 minutes. Once you hit 8 minutes, you can bill that code. What they're saying is, in the CPT E&M section, If the code has a threshold amount, you have to get to that threshold amount. You can't get halfway there. You have to get all the way there for that threshold amount for that code. So one of the other things we need to talk about that CPT's delving into that they never have before is the split shared guidelines. Now, I have been teaching split shared for 20 years. I actually got to meet the person who at CMS, and it was HICFA then, who actually wrote this guideline. I had the chance to meet her at a conference in Baltimore. Um, so I've been dealing with them for a long time. And until now, CPT has remained silent. It wasn't something they addressed. But last year they began to address it, and this year they've expanded on that. So split shared, if you don't work with nurse practitioners and PAs, you don't do hospital services, you may not have come across this. But this is when a nurse practitioner PA working in the same practice as a physician, they work together to see the patient on the same day. And again, this is for Medicare, we've always talked about it being hospital, emergency department, inpatient, outpatient, but it had to be hospital. So CPT got into this year and said that here's some guidelines for when the physician is working with a qualified healthcare professional. That's the terminology they use. CPT calls them non-physician practitioners. But if a physician is working with that QHP, if you're coding by time, the professional who documents the majority of the time is who bills the service. If you're coding by medical decision making, the individual who approves the care plan and takes responsibility for the management, they get to bill for that service. So they're giving you that guideline there, which is the same as Medicare's. Now, one thing that Medicare does not go into this detail on, but CPT does, is that if you're billing by medical decision making, and you're choosing, and one of the elements that's supporting that decision making is data, then that data has to be done by that billing provider. So whoever is doing that, we have to rely on that. So if they're doing that independent interpretation, their discussion of management, that's supporting the data that is then supporting the decision making, it has to be done by that billing provider there. So kind of that clarification there. Now, two areas that CPT and Medicare do not agree on. CPT does not give a specific site of service for split shared. Medicare says split shared is only inpatient or outpatient hospital, emergency department, and skilled nursing. It's not anywhere else. CPT doesn't give a site of service. Also, CPT does not require a modifier. Medicare does require the modifier FS. So if you use these providers in your practice, compare the CPT guidelines with the Medicare guidelines, and then, again, your other payers, and decide what's going to be appropriate for your practice. For years, some of us have said, we need a code for a GYN exam. It just doesn't quite fit into the other E&Ms. Well, we still don't have a code for GYN exam. This is different. This is an add-on code. See that plus sign? This is an add-on code for a pelvic examination that you will add on to either a preventive medicine visit or any evaluation management service. So really they're looking at it in terms of, let's say we had a preventive medicine visit on a 40-year-old. Well, if it's a man, you've got everything that's done. If it's a woman and they have that pelvic exam, that's more intensity there. So they added this to kind of quantify that. But this is not a physician work um, consideration. This is practice expense only. There is no physician work value associated with this. And it's for that additional practice expense, the nurse time, the equipment, the supplies, all of that. So again, you apply it to, it's never billed by itself. It's always appended to either an E&M code or a preventive medicine code. You will not report it on the same day as the patient has a procedure that requires a pelvic exam. And the example, of course, is colposcopy. When we do that examination of the cervix, of course you have to do a pelvic exam. So it's already built into that colposcopy, so you don't code for it separately there. Vertebral body tethering, that's our first surgical code here. I get really excited about this because I just see a lot of this as new technology that benefits the patient, and this is one of those. I get really excited about this. So this is to treat scoliosis, and a patient, these are usually adolescents that they're treated, their spine is still growing, but previously the standard of care was to fuse that spine. They would have rods and plates, and it would be like a permanent thing, and they're really restricted in motion of their spine then. This looks almost like rubber bands if you look at it. It's a band that goes along the concave curve of the spine, and then over time, 2 years or so, it pulls the spine in a line without having to have that invasive surgical procedure. So you notice this includes thoracoscopy. So if we do that scope into the chest to do this, it's based on the number of vertebral segments. Also notice that that bottom code on there is a category 3 code. And that's important to see that if we're doing it in the thoracolumbar or lumbar area, it is a category 3 code. If we're doing it in the thoracic area, it is a category 1 code. Sacroiliac joint arthrodesis. So this would be to treat chronic hip pain, chronic back pain, and we're actually fusing the joint where the back meets the hip there. Now, we already had a code for it if we did what they call percutaneous pinning. So it's something, a device, a transfixation device they call it, that goes through from the outside of the bone all the way through the bone. This is actually a device or an implant in the joint. So that's the difference. Is it pinning from the outside of the joint, or is it an implant in the joint? And a patient could actually have both. And if they did, you would code both 27278, our new code for the interarticular, and 27279, which is the existing code for that pinning of the joint. They made some revisions to the bunion codes, this is not really, they don't change the code description, but they're clarifying. There's some clarifying language in the guidelines there. So these codes, the codes have always meant that you have to excise the distal medial prominence. Well, what's that? If you have a bunion or you know somebody who has, you know on the inside of the foot, just below the big toe, there's a lump there. And that's where the bone has shifted and grown from this bunion. So if we just fuse the joint and we don't shave away that extra bone, you do not code the bunion codes. You do not code the hallux valgus repair. You don't code those. You'll code just the arthrodesis, the 28740. All of those other codes for bunion repair removal require that you shave, excise, remove that distal medial prominence. We have a code for an insertion of a calcium-based implant of the femur, and this is to strengthen the femur in patients with diseases such as osteoporosis. We have a new code for posterior nasal nerve ablation, and this is to treat a chronic runny nose. Now, this is not ablation of the Vidian nerve. That is much deeper. There's other nerves back in the head going toward the brain. This is the posterior nasal nerve. It's actually, and I hate to say it's a simple procedure, but it is usually done in the office. No anesthesia needed. It is usually a fairly quick procedure. It is done with a scope. And so you remember you wouldn't code a diagnostic scope code with it. You'll just code this surgical endoscopy. And the code is both sides. If you do just one side of the nose, then you're going to use modifier 52 for reduced services. And you have the code for whether you do radiofrequency or whether you do cryoablation. So the following slides, about 4 slides from here, we have codes for the phrenic nerve stimulation system. So it's going to work like our other neurostimulators. It's going to work like our pacemakers, our defibrillators. You're going to have a pulse generator or a battery that then connects to a lead that gives an impulse to a nerve, and in this case, it's the phrenic nerve. The phrenic nerve lies across the top of the diaphragm. This is going to be used to treat severe sleep apnea because basically it is going to be that impulse on the diaphragm that says breathe, 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 breathe. And that is one of the issues with sleep apnea. The patient quits breathing. Well, this tells that diaphragm when to breathe. And so what we're going to have here, and these are in the cardiothoracic section because it's going to be those physicians generally who do it, and it's in that part of the body. So we've got the insertion of the system, pulse generator and leads, including catheterization, all imaging guidance, analysis, diagnostic mode activation. We're going to come back in a minute and talk about the mode activation. And then you have the add-on code for the insertion of the sensing lead. You have a code for removal of the phrenic nerve stimulator. You've got a code for removal of just the leads. You've got a code for removal of just the pulse generator. You've got a code for repositioning of the leads. We have a code for removal and replacement at the same session of the pulse generator of the leads. And then we have codes for analysis and also therapy activation. That's kind of an interesting code here, interesting concept. When we do neurostimulator implantation and we do pacemaker, defibrillator, we want it to start working right away, immediately. However, in some cases with this particular procedure, the diaphragm is continually moving anyway, and so as you breathe in, your diaphragm is moving. So what they will do in this case is they'll implant it and then not activate it for 30 days. That gives time for those sensing the leads to kind of settle in, and stabilize, and the patient kind of to become adjusted to that. And then the patient will undergo a sleep study, and they will then activate it and program it at that point. Because again, it is to treat that sleep apnea. So this is a case where it's going to be about a 30-day lag between when it's inserted and when we're activating it there. So you've got the therapy activation, you have interrogation and programming, and then you've got, if it's done during a sleep study, polysomnography there, and then you have interrogation without programming. So several new codes, all to do with the phrenic nerve stimulation system. We have a new code for dilation of the male urethral stricture. So it's with a drug-coated balloon, and we've started using drug-coated balloons really all over the body. We've used them in the heart with angioplasty. We've used them in the sinuses, and so it's kind of that same concept. We're opening up that blocked urethra with that balloon. Now notice it says including fluoroscopy when performed. So we don't have to use fluoroscopy, but if we do, we can't charge separately for that. And this was previously a Category 3 code. When I first looked at this and I saw it in the urinary system, I'm like, what? What is this? It is a tibial neurostimulator. And I'm like, okay, I know where the tibial nerve is. I remember my anatomy. It runs down the back of your leg. What's the deal here? Well, that nerve actually innervates the bladder. So it's in the urinary system because, it is going to go in the body somewhere else. However, it governs the urinary system there. It's the bladder dysfunction. Now, here's something else that's going to be in a couple of other places as we talk today, and that's this new word, integrated. So this is for an open insertion or replacement of an integrated neurostimulation system. You've got different codes, whether it is subcutaneous or subfascial. Then you have revision removal. Integrated. Well, what does that mean? Generally, neurostimulators, pacemakers, defibrillators, all of those devices have been in two pieces. You have had the pulse generator, the battery, and then it's connected to an electrode. Well, in this case, it's one piece that is the battery and the electrode all in one piece. And that's what they refer to as the integrated systems. We already had a code for this tibial neurostimulator when it was two separate pieces, and that was a Category 3. We got it new, I think, last year or the year before. You'll see as we continue on today and we talk about neurostimulators, we've got new codes in other parts of the body for these integrated neurostimulators. Again, the one piece versus the separate components. Also in the urinary section, we have basically urinary function studies, uroflowmetry, but these are done at home. We set this patient up for this remote system, set them up, patient education. So we've got that code, and then we have the code for actually getting the information back, automated report generation, up to 10 days. So what makes this different? Why do we need a code for this? Why couldn't we just use those remote physiologic monitoring codes that we've had for a couple of years? It's because if you look at those codes, they require a minimum of 16 days of data. Well, this study, we only need 7 to 10, and so it needed a separate code rather than using those remote physiologic monitoring codes. Low-intensity shockwave therapy for the corpus cavernosum. This is used to treat erectile dysfunction, and it is the similar technology that we've used for many years now to treat kidney stones. It's using shockwaves to kind of break out that tissue and open up those channels there. A new code for transcervical radiofrequency ablation of uterine fibroids. Remember, fibroids are those tumors, muscular tumors in the wall of the uterus. Now, we've had other ways to treat them for years. I mean, of course, hysterectomy, but then we've also had laparoscopic ablation and other ways. Well, a laparoscopic ablation, if you think about it, it is ablating those tumors from the outside of the uterus. Yes, we're going into the pelvic area, the abdomen there through a laparoscope, but we're treating them from the outside of the uterus. This technology treats them from the inside of the uterus and uses that radio frequency to do so. We have a clarification, not a new code, but CPT is really clarifying something that's been the code definition all along, but payers kind of had an issue with it, so they've clarified it. 58661 for laparoscopic removal of tubes and or ovaries, is a unilateral code. It's always been a unilateral code, but payers just didn't recognize that. So what they're saying is if you do the left ovary and the right ovary, you should use modifier 50. You should be paid separately for both. Now, if you did the tube and ovary on just one side, then you only use the code once because it's and or. However, again, it's a unilateral code. Always been that way, but now CPT's clarified it. So hopefully that'll help with some of the payers. We have a new code for a skull-mounted cranial neurostimulator. And so this is not that integrated system we're talking about a few minutes ago. There is still a neurostimulator and then the electrodes that go deep into the brain. So it is still two connected pieces there. The difference is instead of this pulse generator being somewhere else on the body, the chest wall, the back, wherever, it's actually on the skull. And so it kind of keeps it closer to the electrodes and then maybe more contained there. So you have the insertion, revision or replacement, then you have the removal. Now notice the removal says with cranioplasty when performed. So if we remove this from the skull and we have to repair the skull, it's just part of it. You don't get to code separately for that. This is like a brain defibrillator. So it's not like a neurostimulator that continually gives an impulse. It actually senses so it's like an ongoing electroencephalogram, an EEG, an ongoing EEG. It senses those abnormal EEG patterns and then responds with that neurostimulation. Here's what I told you we'd come talk about with the difference between the new technology for neurostimulators and the existing technology. Now, I've got those triangles, and I apologize, they're not all really pretty uniform in shape. It's kind of hard to pull that triangle into the PowerPoint and get it the right shape. I also put them in green because anytime you have new language in the CPT book, it's going to be in green. So I've got my little green triangles there. So these are not new codes, but the code description is changed. And I put the changed language in italics. I didn't put it in green because just the issues with making sure that that copies correctly. So it's in black. In your CPT book, it'll be in green, and I've got it in italics here. So this is the added language, and they're really just trying to show, hey, these existing neurostimulator codes are when you have two separate components. Notice they say requiring pocket creation and connection between electrode array and pulse generator. And so again, that gives you that. Now we also have the two on the bottom, 6459095. We also have that added word for sacral. That's new, that these are going to be used for the sacral neurostimulator. I also wanted to point out, we generally are not talking about reimbursement today, but I will point out if this is something that you do, something that you code for, check your reimbursement on the 64590 and the 64595 next year. The work RVU for those is increased significantly such that your reimbursement should increase on those two. Now, your other two stayed the same or went down a little bit, but these increased significantly, so make sure your fees are adjusted accordingly. The peripheral neurostimulator, here's where we have that new technology, that new code with that integrated neurostimulator. Remember, it's that one piece that has the battery, the electrodes in that one piece. So you have insertion or replacement, each additional electrode array, and then the revision or removal. Then the spinal neurostimulator, same idea. This is the integrated neurostimulator. Notice that these are category 3. These are not yet FDA approved. We don't have a category 1 code for them. But again, the same idea. We have this integrated, it's one piece, pulse generator, and then the electrodes together in that one piece. Insertion or replacement, revision or removal, and so on. Then we have the electronic analysis of the implanted integrated neurostimulation systems there. And notice that like our other neurostimulator programming codes, these are based on how many parameters were addressed. We have a new code for electrophysiological focused magnetic stimulation. So this is a magnetic transducer that goes on the outside of the skull and that pushes magnetic waves into the brain. Well, why do we do that? This is actually used to assess brain function within the context of existing brain disease. Then we have a code for a suprachoroidal injection. This is in the eye section. So this is an injection to the potential space between the sclera and the choroid. And you're like, well, what do you mean by that? So remember your anatomy. Remember the sclera is the eyeball. It's the hard outer covering of the eye. The choroid is the very inner layer, the layer in the eye that's closest to the sclera. Well, there's not really a space there between them. However, we can insert a needle between those two layers and inject medication, and that is into that suprachoroidal space there. Now, notice it does say separate procedure. So if you're doing this in conjunction with a bigger procedure, you won't use this code. It's only if you're doing this as the only procedure on that eye that you'll use this code. Also in the eye section, but it is a Category 3 code, is for a subretinal injection into the of a pharmacologic agent. So it's below the retina. This is much, much deeper than the injection we just looked at. But note that this also includes a vitrectomy and one or more retinotomies. Remember what a vitrectomy is. The vitreous is that gel that's kind of in the middle, kind of in the back part of your eyeball. Now, when we're born and as we grow, that gel is necessary. It needs to be there because for the development, the shape of the eye. But as we age, that gel can actually cause problems and actually pull the retina away from the back part of the eye and cause blindness potentially. So in this case, we're treating that we're removing the vitreous and we're actually putting a hole, a tiny little hole in the retina, and injecting this medication in there, just to treat some of those retinal diseases. Here is our one new radiology code, and it's for fractional flow reserve with a CT imaging there. So in this case, we have a patient that's had a previous coronary CTA, and we're going to take that data, we're going to run it through some software analysis, and we're going to come up with that value of the fractional flow reserve. So this is, again, a previous CT. We do that analysis. Here's our code. We did have an existing code if we did it during a procedure, and so that is the 0523T there. And then we have 4 new codes for intraoperative epi-aortic ultrasound. So these came about because we do have the one code for intraoperative ultrasound guidance 76998, but it's one code all over the body, different physicians using it, different procedures it's being used with, and it really didn't always capture the exact amount of work for some of these more intensive procedures. And so that's why we have these 4 new codes for the intraoperative epi-aortic ultrasound. So we're doing an ultrasound surrounding the aorta. So you have the 76984 for the diagnostic, 76987, 88, and 89 associated with congenital heart disease. And so you've got kind of the global code 76987, which would be placing the transducer, doing the image acquisition, and doing the interpretation report. And then you've got the other 2 codes if you're doing just part of that. Pulmonary tissue ventilation analysis. So similarly to we talked about the CT, the fractional flow reserve, a couple of slides ago, this first code is taking an existing chest CT, and we are going to process some data to determine what is that pulmonary tissue ventilation. Now, it talks about cinefluorograph images. Well, that's a big fancy word that just means X-rays of an organ while it's in motion. Cine means motion, fluorograph is the X-ray. So we've got images of the lungs while they're in motion, and we're able to use this analysis to get this pulmonary tissue ventilation. And then 0808T is the same idea, same kind of results we're going to get, but it is done in combination with a CT being taken just for that reason. The 0807T, we have a CT taken for some other reason. And so again, just the same kind of the same results, but different basis for doing it. We have a new Category 3 code for ultrasound-based radiofrequency echographic multispectrometry axial bone density study. Lots of words. But basically, you may remember that for the past few years, we've had several new codes to measure bone density and a patient's fracture risk. So this is kind of the same information we want to get, but instead of using regular radiation that has perhaps some potential side effects, this uses ultrasound technology. So there would be less side effects to the patient for this. So again, we're trying to get that same information about bone density. Super excited about this code. I told you I get really excited about new technology. As a breast cancer survivor, I get really excited about anything that helps us better image the breast, helps us better to determine whether it's benign or malignant without necessarily having a biopsy and some invasive procedures. So you'll see this is an add-on code. We add it onto ultrasound of the breast, and it's going to give just a much more detailed image. It's very, very cool. You can actually, if you want some more information or see some images, you can actually do an internet search, optoacoustic imaging. Very, very cool. Ultrasound can show you the size and the shape and a little bit about the density of a mass in the breast. This actually can show the blood flow into that mass, and it can show the oxygen concentration in that mass. And so, for example, a malignant mass is going to have a higher oxygen concentration. It's going to be higher blood flow into it. And so, as opposed to a benign. So there can be some determinations made or some pretty good guesses made about is this benign or malignant, and this may have us doing fewer biopsies that turn out to be benign. We're always glad they're benign. However, we've gone through that trauma of the biopsy, the anesthesia, and all of that. So just really exciting to see this kind of technology. So take a look at that if you're interested. Do that internet search, and I believe the website actually has this banner that says "We see cancer in color," which is just a really cool idea there. Then we have two new codes for quantitative MRI of the brain with comparison. So again, we're looking at the brain volume and then the severity score of lesions perhaps within the brain. And so you've got that analysis comparison with the prior MRI. And again, you've got that two different codes based on if you're doing it, if you're obtaining an MRI at the time or you're doing it on a previous MRI study. Now I'm going to talk about this technology right now, right here, and then in a few minutes I'm going to talk about the same technology, but used for a different reason and two different codes. So here we have the spectroscopy study for a wound or a flap. So this is an existing code, but the first one on the slide is an existing code. We've got that triangle. We've got that change in language. Then the second code is a new code for another anatomical site. So this is using infrared technology to measure the blood flow at the site of a wound. Wound care is a tremendous field, lots of challenging patients there. We can do everything we can, all this different external treatment of a wound, but if there's not sufficient blood flow into that wound, it's not going to heal. So in this case, we're analyzing that blood flow into the wound, and it's based on each anatomic site. So if the patient had multiple wounds we're imaging, we would code 0640T for the first site, 0859T for each additional anatomic site that we're imaging. So again, think about that technology. And what I do is when I get these new codes, I actually do a lot of internet searching. I want to see the technology. I want to see pictures. Sometimes they show us that at the symposium, but if they don't, I go looking for it. It was really hard to find one that wasn't really gross because they showed you the wound. I don't want to see the wound, but it shows in color where there's blood flow going. So it's very, very interesting there. So again, keep that in mind. We're going to come back to this idea, but for a different reason in just a moment. In the Path and Lab section, we had several changes in code descriptions that are actually come about as a result of a 2017 law called Rosa's Law that requires government agencies and all federal law to change the wording from mental retardation to intellectual disability. And so that's just what CPT is doing here now. So we had some revised guidelines for the genomic sequencing procedures, and then the molecular multi-analyte assays. We had new codes for the MAAA. We had revised guidelines for unlisted codes, and all that it does is it points us to what is the appropriate unlisted code for this section in the Path and Lab section. So it kind of gives you that guidance. They also added parenthetical notes to the pathology codes so that you'll know which add-on code for digitization of slides. Last year we got new codes for digitization of slides, but they vary based on what specific base pathology code, and so it just gives you that guidance. And then we had 70 new PLA codes, and we've already mentioned those a little bit. Here's your new Path and Lab codes. I'm not going to take the time to go into each of these. I'm just going to leave them with you here. Two new microbiology codes, that's SECA, one for orthopox virus, monkeypox, cowpox, vaccinia, all apply there. And then we need to talk about the vaccine codes. I got some good news for you. Maybe you've already seen this good news, but I've got some exciting news to me. So, but first, before we do that, I just want to take a minute to remind you why we've got some coding differences in this section and what the difference is between vaccines and immune globulins. You will see two different sections in the CPT book. You'll see that the administration is coded differently, but I want to just make sure we understood a little bit about it. I always think the more we know, the better off. So vaccines are always for prevention of disease. They're derived from live or inactive bacteria and viruses, so the actual virus or bacteria. They stimulate the immune system in the body to produce those antibodies. They provide what is called active immunity. Immune globulins, on the other hand, can be for prevention or for treatment. They're not derived from the virus, they're derived from existing antibodies. They do not stimulate the body, they do not stimulate the immune system to produce antibodies, they give it antibodies, and it provides passive immunity. Well, the big thing you need to know about active immunity versus passive immunity is that active immunity takes time to develop. So we give that patient the vaccine, they're not going to be immediately immune to that disease or that virus. It's going to take time. However, once that immunity develops, it is going to be very long lasting, years and years and years. Passive immunity, on the other hand, the type of immunity that comes from immunoglobulins is available immediately, but it doesn't last very long. And that's why those may have to be repeated seasonally, yearly, whatever for that immunity. Now, look very carefully in your CPT book as to what you're looking for. Is it in the immune section? If it's in the immune globulin section, that means, read the guidance, you will use different administration codes than you would if it was a vaccine. In some cases, it sends you to the therapeutic injection code. In some cases that I'll show you today, we actually have a separate immunization administration, but it is not the same as the vaccine administration code. Then you get over in the vaccine section, and again, make sure that you're choosing the appropriate administration code based on whether it's an immunization or a vaccination. We kind of use those terms interchangeably, but they're not. Here is your good news. Hopefully you've seen this. CPT, after the book was printed, they deleted 64 codes and Appendix Q. So you've got, 3 or 4 pages in your book that you're not going to use anymore. Yay, because it was really very complicated. So the AMA decided, again, after the book was printed, we don't need all those codes anymore. So again, they've deleted these. Your book is already out of date. You haven't even got to January 1st. So in this section, your book's already out of date. Here is always the best, most up-to-date source for COVID-19 vaccines. Now, I'm going to give you the link. We have the link for the other immunizations because we do have some of those that are not, also not in the CPT book, but this is the biggie. All of those codes that were based on, is it the first dose, the second dose, the booster dose, all those are gone. Now it's one administration code. You do still have several product codes based on which product it is, and we do have 5 new product codes for this year. So you'll still have to make sure which product you're using, but it's going to be the one administration code, 90480, COVID-19 vaccine, single dose. So you don't have to worry about all those other by product or by dose anymore. Here's your new vaccine product codes, again, for 2024. These actually were effective November 1st of 23. Now, in your code description, the part that I have at the end of each code in italics, that is not the official code description. I added that with information from the AMA website. So that first one is 6 months to 4 years. It gives you all the information about mRNA, LNP, spike protein, all of that, but that is the Pfizer vaccine. 91319 would be also the Pfizer, but age 5 to 11. 91320 is also the Pfizer, but it's 12 years and older. And then 91321 and 22 are the Moderna, again based on age. And this comes from the the FDA requesting manufacturers to update their vaccine composition to be the monovalent, specifically based on the Omicron variant. They felt like it was the dominant strain in the US. It's the most divergent strain, but this is going to give a better match for what's out there now. Two other new vaccines. Notice these both have the lightning bolt symbol. Remember what that means? That means that at the time the book was printed, this vaccine was not yet FDA approved. But they knew it was in the pipeline to be approved, and so they went ahead and gave us a code so you'll have it, and we won't have to use an unlisted code. Think about it. If they didn't give us a new code till after it was FDA approved, we would potentially have to use an unlisted code until the book came around again, or they updated the codes in July or whenever that was. So we've got the code, we're ready whenever we start giving it. Chikungunya, that's mostly going to be a travel vaccine. It is a mosquito-borne illness, but it's not something we see much in the U.S. It's seen a lot in other countries. And then the meningococcal, we already had a code for meningococcal vaccine, but it was for the quadrivalent, which would be 4 serogroups. This is for the pentavalent, which is 5 serogroups. And then on this slide, you have the address for all immunization coding. Again, the best place to get it is directly from the AMA website. Two new codes for RSV in children, 24 months and younger, and here's where these are not vaccines. These are immunoglobulins. They're in that different section of codes there. And y'all, pardon me, there is a typo. That should be 90381, not 90831. I had a little coder's dyslexia there, got my numbers confused, but it should be 90381. I apologize for that. So make that note on your handout there. And then you've got the specific administration for this RSV, and this is a seasonal dose. Now, this, however, is similar to our vaccination administration codes in that we have one code if we do counseling and one code if we don't do counseling. And remember, counseling has to be by the physician or other qualified healthcare professional, have to document it. Now, why does this not mention age? You remember our other vaccine codes with counseling mention age. This doesn't mention age because it is only for these two vaccine codes, and these are only given to toddlers, infants 24 months and younger. So there was no point to give age when the vaccines, immunization, not vaccine, immunization is only given to these patients. We have two other new RSV vaccines, and these are both used in adults 60 and over. I was having a little chat with my prayer group last night about I'm elderly. No, you're not. I said, look, CPT says 60 and over, you're elderly. I'm elderly. So you've got, and notice you also have one here that has the lightning bolt symbol. So, I mean, it's not FDA approved yet, but it should be coming soon. RSV is something we've always thought about as affecting infants, and it truly does. But more and more elderly adults over 60 are affected by it. I have a friend who got RSV from her granddaughter and spent 2 weeks in the hospital, very, very sick with that. So we already have the existing code that we're still going to have, but is used for adults 60 and over and pregnant patients 32 to 36 weeks. We have a new code for the processing, analysis, verification of an auditory osseo-integrated sound processor. This is not a cochlear implant. It does improve the patient's hearing, but it is not the cochlear implant where the electrode goes into the cochlea. This is a bone-anchored hearing device where it's anchored onto the bone and the sound waves transmit through the bone of the skull. Coronary lithotripsy, this is an add-on code, would be added on to a cardiac catheterization when we use that shockwave therapy to break up that plaque. Like we talked about with we talked about in other parts of the body, it's those shock waves, and this is an alternative to atherectomy. Atherectomy is what I call the roto-rooter procedure. They put a cutting tool in the coronary artery and try to cut away that plaque. In this case, they're going to use shockwaves. And in fact, the company that developed this, the name of it is Shockwave Medical. That's just a cool name for a company that does this coronary lithotripsy there. Venography for congenital heart defects, and notice these are add-on codes. They're going to be done at the time of a cardiac catheterization for congenital defects. So you will only add these on to those specific congenital heart defects codes, and then again, these are going to be specific as to which particular vein that you're imaging there. New Category 3 code for transcatheter pulmonary artery denervation. This is used to treat pulmonary artery hypertension. Then we have several slides here for dual chamber leadless pacemakers. We've already talked about the technology where you have the battery separate from the leads. Well, in this case, we have one capsule-sized device that includes the battery and the leads that are going to, give that heart the electrical impulses it needs. So when we talk about dual chamber, that is one part of the device in the right atrium and one part in the right ventricle. Now, we can have a device in just one or the other, but when it's a dual chamber, it means we have that. We have components in each of the ventricles, the right atrium and the right ventricle, each one of those chambers of the heart. So you've got 0795T when it is the complete system, 0796T when you're adding the right atrial when they already had a right ventricular, and then 0797T when you're putting the ventricular in when it's part of this dual chamber. Here we have the transcatheter removal of the complete system, or just the right atrial pacemaker component, or just the right ventricular pacemaker component. Then we have the transcatheter removal and replacement of the permanent dual chamber, again, when we're doing the right atrial and right ventricular pacemaker components. So if you're doing these, you're going to examine these very carefully to see exactly which component we're inserting, removing, and whether and which is the right atrial, is it the right ventricular, and that specifically. So this is the removal and the replacement at the same session there. And then we have the programming device evaluation. This one specifically says in a person with that iterative adjustment. And then the right atrial leadless pacemaker. In this case, we've only got, it's not a dual chamber. We don't have the component in the atrium and the ventricle. We have it just in the right atrium. So again, we have the insertion, removal and replacement, the device evaluation, removal, all of those different options. We have codes for SVC, IVC, prosthetic valve insertion. This is the superior vena cava and the inferior vena cava. We already have codes for different valves in the heart. The valves in the heart prevent the blood from backflowing where it shouldn't go. So the blood goes through, the valve closes out. Well, in this case, this is the two major blood vessels that bring the blood back to the heart, one from above the heart and one from below the heart. And so in this case, we need to replace those valves. Is it done through a percutaneous femoral vein approach or an open femoral vein approach? In this case, what percutaneous and open refer to is, are we visualizing the vein as we insert the catheter into the vein? Not that we're visualizing the heart or the vena cava. Are we visualizing the femoral vein? Here is that other code I told you we'd come around to. This is the infrared imaging of blood flow, but it's not to the wound. It is just to the lower extremities. This is a screening for peripheral arterial disease. So we're trying to see, is the blood flowing to the lower extremities as it should? So it's not. So it's the same technology, but we don't have a wound that we're focusing on. We're looking at the whole extremity there. This also includes what they call provocative maneuvers. So we are doing things to the leg to see if the blood's flowing appropriately. And you can kind of think of it as maybe like a blood pressure cuff on the leg that's inflated and kind of squeezes, and is the blood going to flow past that? That kind of idea. But again, it's an image that's produced that's colorful, and you can see, is there blood flow or is there not blood flow? Wireless cardiac stimulation system for left ventricular pacing. So again, this is stimulating that left ventricle. You've got that pulse generator, and you've got the battery, the transmitter. Hyperthermic intraperitoneal chemotherapy. I did this update presentation for a group last night, and one of the coders was so excited because her providers have been doing this, and there was just no code for it. So this is chemotherapy inserted during an operative session. And this is going to be a code for the surgeon to supervise that, or the surgeon to have this done while they're, again, supervising this. So this would be a gynecological oncologist, a gynecologist, urologist. We're removing some sort of malignancy from that patient's abdomen, peritoneum, retroperitoneum. We're removing a malignancy. And while we still have them open, or while we're still in there, we're going to push this superheated chemotherapy in that space where the malignancy was. So we're able to target very specifically that malignancy, use that specific drug, and add that component of heat to it. So these are add-on codes because it's going to be added on to the surgical procedure, because again, this is going to be done by that surgeon. So we have the first 60 minutes, we have each additional 30 minutes, And then there was a revision made to 96466 to distinguish it from this service, this code. And that is the chemotherapy administration via an indwelling implanted portal catheter. So patient can have chemo into their peritoneum, into their abdominal area, but if they've got an implanted catheter, they're going to go in, on a regular basis to the infusion center, the cancer center, and have that chemotherapy pumped in. So first of all, it's not done heated, and it's not done at the time of the surgical procedure. That's the difference between these codes. Postoperative low-level laser therapy, that's a cold laser, and this is specifically applied for postoperative pain. This requires that constant attendance of the physical therapist or that professional there. And then three new codes for caregiver training. And so you want to take a look at this in conjunction with some of the Medicare changes for next year, in that we have coverage for what they're really trying to do. CMS is trying to take better care of patients with these serious chronic conditions. And in this case, we're teaching their family members, their caregivers, ways to take care of them at home. That's kind of the idea here. So 97550 and 551 is for training one patient's caregivers. It can be multiple people, multiple caregivers, but the idea is it's one patient. The patient is not present, but we're training that patient's daughters or caregivers, someone, what they need to do to move them, to feed them, safety, those kind of things. So again, patient not present, it is face-to-face, it is just one set of caregivers. So for example, if my sisters, my two sisters and I had some initial training on helping care for my brother. My brother's in a wheelchair. He does great, lives by himself. But if he ever got to the point where he needed more help transferring and things progressed, then if they trained the three of us, it's still that one code because it's based on the number of patients that you're addressing there. Then the 97552 is a group caregiver training. Again, patient not present, face-to-face with multiple sets of caregivers. That's the difference there. These are covered by Medicare, and they're part of, as I said, the overall idea that we need to provide better ways for that patient to be cared for outside of a facility. Now, you cannot use this code if the patient is receiving home health care because they're receiving that from the home health agency. Medicare is paying that agency. This is if their family, someone else is caring for that patient. We also have a new code for virtual reality facilitated motor cognitive training. I just thought this was cool. This is another of those cool things that Kim thinks. So this is an add-on code to GATE training. GATE training is done, it's a physical therapy code. It's done when that patient's had a stroke or an injury, something where they need to learn to walk again. Well, this is using virtual reality to teach them not just the mechanics of walking, but how do you walk when there are distractions? How do you spot objects? How do you navigate to different locations? And so I joked and said, it's kind of like teaching, walk and chew gum at the same time, but it is teaching the patient to walk and manage everything else that goes along with walking down the street, as opposed to just walking on a treadmill in a supervised environment. So very cool technology. Pharmaco-oncologic algorithmic treatment ranking. So this is taking a cancer patient's pathology report, all their tumor markers, all their labs, and analyzing it to design the best chemotherapy regimen for them, and not just a one-size-fits-all treatment. It really is focused on that patient's specific tumor markers, pathology, and all of that. When I saw this one, I really had to laugh. I'm like, what? What is this? So this is when a patient self-administers a psychedelic drug, and then they are monitored by a physician or other QHP. Now, the reason the patient has to self-administered is it's not legal for us to administer a psychedelic drug. But the patient's taking whatever that drug is, and then the doctor is going to observe them for a period of time, and that's for safety reasons. That is to intervene. That is to do something if there needs to be something done to take care of that patient. Why in the world would we do something like this? And this is actually a potential treatment for depression, for PTSD, for substance use disorders. So you have the first code for the first physician each hour. Then you have a second code if there's requires to be a second physician or QHP concurrent with the first. And then if you also have clinical staff concurrent with that first physician. So the add-on code for the time there. have got a code for application of fluoride. Now, we already had a code for application of fluoride. Why did we need a new one? We had 99188. There's actually some pediatric practices who do that. The difference is the 99188 is a prevention. It's basically painting all of the teeth with fluoride. This one is specifically to treat dental caries, dental cavities, and it has very specific intentional application to those very specific areas with more attention to detail and technique there. Those are the new codes. We do need to talk about changes to 3 of the appendices in CPT. And actually, we could mention the 4th. Appendix Q was deleted. It's gone. It was those COVID-19 administrations. You can kind of rip them out of your book or cross them through or whatever you need to do. We have some revisions to Appendix S, which is the Artificial Intelligence Taxonomy. If you have not looked at this, I encourage you to do so. This is how we're using artificial intelligence in the healthcare field. The AMA has done some great education on it and some analysis of how these things fit. So if you've not read this appendix, go read it. It's very interesting. You're going to understand better what's coming in healthcare. Now, I'm not going to go into detail, we just don't have time today, but basically there are 3 levels of artificial intelligence. There's assistive, there's augmentative, and there's autonomous. I don't have assistive listed on this slide today because there's no change to the assistive. I only have the changes here. Assistive artificial intelligence basically takes all the data about a patient or everything, gathers it all together, organizes it, says, here, physician, here's your data. Augmentative takes all of this data, organizes it, and then gives you a meaningful output. Here, physician, here's your data, and here's what we think about it. And this is where we have the change, and now it says yield clinically meaningful output. So they just changed the wording there. Then the 3rd level is autonomous, where that machine takes all the data, analyzes it, and then says, this is what we're going to do. And so there's different levels there, and one of the things they changed here is the wording to say, if it's autonomous AI, it is going to require physician or QHP initiative to contest what the machine is doing. So take a look at very, very interesting stuff in this Appendix S. Changes to Appendix P and T. Appendix P are those services that are usually done in person, but that the AMA CPT editorial panel decided that they can be done synchronous audio video. Modifier 95 is applicable here. Appendix T, again, are services that are normally done in person, but the CPT editorial panel decided that they could be done through synchronous audio only. Modifier 93 is associated here. Now, they just want to make sure that it is effectively be performed by synchronous telemedicine. Now, there is one thing that I'll mention that's not on this slide that the AMA did say, that for the first time ever, they reviewed the services in Appendix P, and they ensured that they are payable, or there is a payer policy. At least one payer in the U.S. addresses this service through payer policy. So not that everybody pays for it, but there's at least one payer that recognizes it as a synchronous audio video service. So again, not everybody's going to pay for it, not necessarily Medicare, but at least one payer does, and that's those in Appendix P there. Phew, I'm going to take a breath here a minute. I'm going to take a sip of water. And Samantha, if you'll check and see if we've got any questions, we'll see if we can address those.
Great, thank you so much. To join the Q&A session, you may type your questions in the chat box within the webinar control panel. I will ask the questions on your behalf. Questions will be taken as time permits. Okay, our first question. Do you have the CPT code for administration for the RSV vaccine for peds and adults?
So take a look in your CPT book. If it is that seasonal that's new, then you've got those on the slide there. If it is not the seasonal, then you are going to use whatever is the appropriate therapeutic medication administration code. And all that's given in your CPT book. It may be the 96372. It is not the same as the vaccination. So again, if you're looking in your CPT book, and you look in the very front of the medicine section, there's your immunoglobulins. Those are immunizations. They are not vaccinations. So again, that's why I went into that explanation of immunization versus vaccination and what that is. So if you're looking at the very front of the medicine section, ahead of the immune globulins, it tells you these are reported in addition to the administration codes, and it lists 96365, 6667, based on, is it IV, is it IV push, is it sub-Q. Be careful, don't use the vaccine administration codes for vaccines in that section. You'll use those therapeutic medication administration codes instead. Now, and you asked specifically about the RSV, RSV falls in that section. So aside from that, the two new codes that we had for the seasonal RSV, you would use those, the therapeutic medication. But all of that is outlined in the front of the medicine section, where you've got the immune globulins first. You've got a paragraph there that tells you which administration code you're going to use.
Great, thank you. Which type of providers, MD, nurse, PT, OT, etc., will be allowed to report the caregiver training codes?
So that's going to be interesting. We're going to have to wait and see somewhat how the payers respond. So it's going to depend on how you're set up. If what I'm understanding is that they're mostly going to be, it's going to be done by a trained individual. Depending on your practice, that trained individual might be a nurse. It might be a nurse practitioner. It's going to be reported by the billing entity there. So in a lot of physician practices, well, first of all, nurses, those folks don't have their own billing numbers. Nurse practitioners, of course, should. Hopefully you've credentialed them. So it depends on that. Now, if you've got a physical therapy in your office, then it may be reported on under the physician. It may be reported on the physical therapist. If you're doing them as a rehab facility, which is possible, however, it's going to be reported through that facility. So however that billing normally works for those types of, they're really kind of rehab physical therapy codes. It just depends on how your billing is set up there. So the person is going to have to be trained. Uh, excuse me, the person doing the training has to be trained. They have to be qualified to do it. And a lot of times, what I'm understanding with talking with folks, it's going to be largely rehab folks, physical therapists, physical therapy assistants, and how their billing works is kind of set up in general. So if you're set up to bill under the physical therapist, you'd bill under the physical therapist. If you're set up to bill under the physician, then you'd bill under the physician as they're providing that supervision. Because notice it does say under the supervision of a physician or other qualified healthcare professional. So it's something you're going to need to look at in how your billing is set up. Again, I just can't answer that specifically because I suspect with as many attendees as we have here, we've got some facilities, we've got some physician practices that have PTs, but we bill them under the physician, some where we bill the PT as a separate entity. So again, it's just going to have to be under that supervision of the physician, whoever's supervising and normally would bill for those types of physical therapy services.
Great, thank you. For a split shared visit, can the NP document what the doctor did and the doctor sign?
So CPT doesn't get into that. For Medicare, no. Sorry, I'm going to get a little adamant there because it's just something I see. The physician has to document their own decision making. When you say in the physician sign, well, how do I know it's that physician's decision making? So we can't have an attestation. We can't just have a co-signature. It's got to be clear what the work of each one of those did. CPT doesn't get into that, except that how can we prove that this is this person's decision making if they don't document it? So I'm pretty adamant about that, but look for some further information from CMS. CPT said what they've said. They're not going to say anything else about it. So it depends on the entity you're billing to, but if you're billing to Medicare, go look at the CMS regs on that in conjunction with this. So my quick answer is no, because I've got to know whose decision making was whose.
Great, thank you. What provider types can bill 97550 and 97552?
Yeah, we've already addressed that. It's just going to, this is on the physician pro fee side. So it's going to be physicians, qualified healthcare professionals like NPs, PAs, but who's doing it, maybe it's going to be under their supervision. Physical therapists, possibly occupational therapists. So we're just some of that we're still waiting on Medicare or whoever that entity is. So we don't want to assume it's all Medicare. It might be other payers, and so whatever billing requirements they have. So because for example, I know some of the payers that we work with, they allow the physician to bill for the physical therapist working for them. Okay, then it'd be billed by the physician. Some require it to be billed under the physical therapist. So that is going to be payer specific. So yeah, I can't give a definite answer on that.
Great, thank you. What are the codes for telehealth, phone, and video services we should bill for 2024? Is it the same 99202 to 99214 with modifier 95 as we've used this year?
So you've just quoted codes that may be based on a specific payer because Medicare will pay 99215. So what you're going to have to do is check each individual payer. For Medicare, it is going to be the same rules that we followed last year. All of those were extended into next year, but not all payers did that. So you're going to have to check each individual payer again on that. They're not required to cover telehealth. Most do in some form or another. For Medicare, again, it's going to be the codes that you used last year. And what you just described was if it was an audio video, not just phone, remember, you have the separate phone call codes. So again, for Medicare, you're basically going to follow the rules you did last year. Other payers, you have to check with each payer.
Great, thank you. When documenting a chaperone for the 99459, do you have to note the specific person's name or is chaperone present good enough? Do you have to note specifically what the chaperone did or just that they were in the room when it was performed?
Now, say 99459 doesn't say anything about a chaperone being required. I use that as an example of some additional practice expense. That doesn't address chaperone at all. Your question of the chaperone and should they be identified, that's really more of a question for your professional liability carrier. That's a question for, some of that as opposed to a coding. Because again, that code does not say anything about a chaperone. It just says you did a public exam. So, again, that was my example for, one of some of the additional practice expense. So that question would need to be addressed probably with I know that the professional liability carrier I do some work with, that's part of their recommendations is you always have and the other place you might see that recommendations for that would be from like American Congress of OBGYN. They may have some recommendations on that in their patient care information there. So it's not a coding issue.
Great, thank you. For the psychedelic drug monitoring services, do we bill that on top of a psychotherapy code or does it need to be billed on its own and includes the psychotherapy session in that code, in that new code?
So you would not double count your time. If part of your psychedelic drug monitoring involves some psychotherapy, you just couldn't count the time twice. So you could bill it in addition to that psychotherapy code. Just make sure, because psychotherapy codes, remember, are based on time. You just can't count the same minute twice. So just keep that in mind.
Great, thank you. Is the RSV injection payable?
That's a payer specific question. Do payers pay it? Now, I can in general talk about Medicare and that kind of reimbursement. Um, I every payer is different, so I can't necessarily say what their payers are going to pay it. I will tell you that the RSV is not one of the four immunizations that Part B Medicare covers. It might fall under Part D. But again, and I suspect if you're talking about the new codes, those are for infants anyway, or two of them are for infants, and that's not going to be Medicare. It's going to be Medicaid. I will say most payers I've seen do cover them. But again, payer specific question.
Great, thank you. Do the additional codes require a modifier?
I'm not sure which additional codes we're talking about. So, in general, I'll just answer in general. In general, add-on codes, you do not have a modifier on there. Um, and specifically, what CPT says, if you have an add-on code and you do it on both sides, you don't use modifier 50, you have to list the code twice. So in general, you don't use modifiers on add-on codes, but I'm not sure that was the question, but that was my interpretation of the question.
Great, thank you. What can you tell us about the use of G2211?
Nothing today because I don't mean to be flippant. Today was focused on CPT. That's why we did not talk about G2211. We talked about G221 last week when we did our Medicare physician fee schedule update, and you could certainly contact Training Leader to get access to the recording from that. But we didn't talk about G2211 because we're talking about CPT today.
Great, thank you. Can an RN bill for pediatric vaccine counseling 90460/90461?
No. So the short answer is no. Here's why. First of all, an RN can never bill under her own name, right? And that's the distinction between a physician, other qualified healthcare professional. Other qualified healthcare professional means someone who could bill for this service. RNs can't bill for that service. So the counseling has to be done by physician, nurse practitioner, PA, clinical nurse specialist, someone who follows under that criteria that says they can do the service by virtue of their training, their licensure, and they could bill for that service under their own. Whether they do or not, they could bill for that service. So an RN cannot do the counseling as required for 9046061 or the two new administration codes for the RSV. They've got to be by a physician or other QHP.
Great, thank you. Is it appropriate to use the pelvic examination add-on code for women's wellness visits when we are billing a regular physical code but reporting the diagnosis code as an encounter for a gynecological exam?
Yeah, that's exactly when. So a couple of things here. It's exactly when you would use that CPT code. Because it's that extra work there. And the physician at the symposium who explained this code is a gynecologist, and she explained that's what it's for. She didn't get into the diagnosis coding, but yeah, it would be appropriate for that. And remember, there's not always CPT doesn't always address the diagnosis codes, but that's exactly when you would use it because you're using the preventive medicine code that's the same preventive medicine code that you would use for a man. So how do you show you had the extra practice expense of the pelvic exam? You add on the new pelvic exam code.
Great, thank you. And this will be our last question for today. What procedure code cannot be billed with the 52284 urethral balloon?
Okay, so you would not bill. So just the general cystoscopy rules. Remember, is that you can't do a diagnostic with it. You can't do another code with it if it is. So you wouldn't do the diagnostic with it. You wouldn't do another code for dilation with it. So if you're treating the same area, that's kind of the general cystoscopy endoscopy rules there. So and you would also make sure not to confuse this with the procedure for the prostate. So this is the urethral stricture. There's a different code for a prostatatic stricture there. So pretty much, I think you'd probably only. I think you'd only build this code, but specifically, you wouldn't bill with the diagnostic cystoscopy. You wouldn't bill it with any kind of procedure for the same area of the urethra.
Great. Thank you so much. We would like to thank Kim and our participants for joining us today and remind you that today's session was recorded and available to you at no charge. Join us for their upcoming webinars. Visit www.hctrainingleader.com for more information about all of our training sessions. We will conclude the webinar at this time. Thank you again for attending today, and we hope you have a great day.